We are doing molecular profiling now routinely in colon cancer, but remember that's a small subset. There, like in lung cancer, have been new discoveries of fairly rare mutations, and they are also seen in colorectal cancer. And so as we do more profiling, as we do more broad testing, we are uncovering some unexpected needles in the haystack. I'm a strong advocate for this and realizing that most of the time using our current assays, you're not going to find some amazing lock which we have the perfect key for, but every now and then you do. So I would say keep fishing. We're moving forward in this to develop better biomarkers, not just to find new medicines, but to actually improve our performance with our current medicines. Because let's face it, we try medicines, cross our fingers, give them for a few months and see if it worked or not. That's a huge amount of waste and toxicity if we could figure out beforehand that the patient wasn't going to respond to the treatment. And so you name the drug, whether it's oxaliplatin or irinotecan or EGFR therapy, even bevacizumab, immuno-oncology. If we could figure out who's responding and who's not, that would be incredibly valuable to us and our patients. And so those new biomarkers are being developed and are being brought forward to make us better docs, not just to add to our list of drugs to try, but to improve our performance.
Mutational status in colorectal cancer does change. Now, one of the mutation status that has been studied extensively is the RAS status. We know that patients who are RAS wild type who get EGFR drug, over time, as they develop resistance to the drug, they will develop RAS mutation. Therefore, this was studied in a series with liquid biopsies. Now, in terms of other mutations where MMR, the BRAF, does that change over time? I think more research needs to be done in that area. In colon cancer, a serial biopsy may have some benefits. By doing a serial biopsy on patients, you could actually possibly monitor the response to treatment or possibly pick up some of the resistant mechanism to certain treatment. However, there are certain disadvantages of doing a serial biopsy. Number one is that you're not capturing the whole tumor heterogeneity. By doing a biopsy of one area, you're not capturing the whole real-life evolution of certain mutations. Second of all, it's just not practical doing a tissue biopsy on patients every time they progresses. So currently at this time, other than in trial basis, serial biopsy is not recommended unless if it's indicated per trial. Liquid biopsy in colon cancer is not ready for prime time. Still, I think the gold standard is that you need to get a tissue biopsy and assess molecular abnormalities from the tissue. However, there are possible potential advantages of using a liquid biopsy. Number one is that you could actually capture the resistant mechanism or possibly monitor the response to treatment in real time. And there are other potential applications for liquid biopsy as well. Number one, it could be possibly a prognostic biomarker. There's data that checking a liquid biopsy with a circulating DNA can predict, can be prognostic in terms of the response rate, the PFS, and overall survival. Second thing is that there's a trial done in China that was presented this year stating that doing a liquid biopsy in early on can actually detect early colon cancer as well. So therefore, those are the couple of advantages of liquid biopsy. Now, I think in the future, as there are more data that comes out from liquid biopsy and the technique improves, hopefully the liquid biopsy can possibly replace a tissue biopsy in the future.